All right, so I'm going to discuss evidence-based management of urethral strictures. Urethral stricture disease, so this clarifies the semantics and the terminology. So strictures refer to focal and acute processes. The etiology is usually iatrogenic or external trauma, whereas stricture disease refers to a long spongiofibrotic process, and the etiology is usually inflammation or infection. Studies have looked at this, and broadly, a third of all strictures are from an iatrogenic cause, a third are idiopathic, and then a third are either inflammatory or traumatic. Our workup is pretty standard, is a urethral PVR, cystoscopy, a rug, and then if the strictures in the penile urethra, we will also bougie these patients in the clinic. And so when do symptoms manifest? Typically symptoms manifest when the lumen of the urethra is less than 16 French, and an IPSS score of over 10 or a Qmax of less than 15 has a pretty good sensitivity for predicting urethral stricture disease. And so we routinely will use questionnaires pre-op and post-op in our clinics for these patients. And so what can we, it's an evidence-based management talk, so how can we bring the evidence to bear on the question of what the most accurate modality to diagnose an anteurethral stricture is? So Goldfarb and Elliott actually looked at this, and they reviewed the data between 1990 and 2015. There have been 10 studies on this topic. They compared the different modalities to the reference standard, which was cystoscopy or intraoperative findings at the time of urethroplasty. And the sensitivity of a rug, a retrograde urethrogram, was anywhere from 80 to 100%. For ultrasound was either as high as a rug or even slightly better, and an MR urethrogram was similar to a sonourethroplasty. The clinical implications, though, for this, and they mentioned this in their report, they still recommend a rug over ultrasound or an MR urethrogram because of widespread availability and the higher cost associated with an MRI. In terms of management and outcomes, there are endoscopic options for managing stricture disease, and there are reconstructive options. And we'll discuss these briefly. So again, how can we get the evidence to bear on the question of what the optimal initial treatment for patients with short bulbar strictures, previously untreated, first-time presentation? So there are a few studies on this topic, and the success rates in the two arms for patients who have had a urethroplasty, it's about 95% at 5 years, with less than 5% of patients having a complication. For DVIU, the success was anywhere from 20 to 30% over a 5-year period. And so what are the clinical implications of this? So we tell patients, if you're presenting for the first time and you have a short stricture in the bulbar urethra, then a DVIU would result in a faster recovery, but a much lower chance of success. So this slide just shows how a DVIU is performed. There's different ways to do this. You can perform radial cuts. You can perform cuts at 12 o'clock. Studies have shown, ultrasound studies have shown that the location of the urethral artery is actually pretty variable. Previously, it was felt to be not the case, but now we know that it's pretty variable. So we just do feather cuts in a radial fashion for our DVIUs. This is data from the 80s and the 90s, and actually shows a pretty high rate of complications with DVIU, predominantly hematuria-related complications and infectious complications. And so this is an important slide. So multiple studies have looked at, again, the long-term success rate with DVIU or dilation. And basically after the first, but definitely after the second DVIU, the failure rate's basically 100%. And so anyone getting a third DVIU, you can tell them it's basically placebo surgery. This is data from a randomized trial published by Haynes et al., which again shows and reinforces the same point. This is a Kaplan-Meier curve with a stricture-free recurrence rate on the y-axis, and the 3 different curves represent outcomes after the first, second, and third DVIU. And so as you can see, after the first one, the rates tend to drop off within the first 5 years to almost 100% failure. And Dr. Santucci actually published outcomes and showed that the success rates are actually even worse than we thought before. So the earlier studies were done in the 80s and 90s, and this was much later. And he showed that the success rate after the first DVIU is actually only 8%. DVIUs do tend to work in certain locations better. So short strictures in the bulbar urethra have a slightly higher chance, and so should be avoided. So we should avoid DVIUs in the penile urethra. And as I mentioned, stricture length. So over 2 centimeters, we don't recommend patients get a DVIU. And so not only do endoscopic options have complications, significant ones, and don't work very well, but they also make any subsequent urethroplasty much more challenging. So a patient that may have benefited from an anastomotic approach, where you can excise the stricture and bring the healthy ends back together, would probably be relegated to a buccal graft substitution procedure because the stricture is now much longer than it was initially. And so not doing repeated DVIUs and dilations is important in this population. The team from the University of Washington looked at the most cost-effective method, and in their analysis, for a patient first-time presentation for a short bulbar stricture, 1 DVIU is acceptable as long as the patient understands that the outcomes aren't as good as for a urethroplasty. But anyone with a recurrence after the first DVIU or for a longer stricture should be counseled that the urethroplasty is the standard of care. So in summary, both DVIU and dilation have similar efficacy. Urethroplasty is more cost-effective than endoscopic management. A single attempt at endoscopic management is appropriate for select patients, but further attempts should be avoided. And now moving on to anastomotic urethroplasty. This is basically flap surgery, right? So you're advancing a flap of urethra, and this it's premised on the fact that the urethra receives a bipedal blood supply. And so even when the urethra is detached from its proximal blood supply, it still survives based on both circumflex arterial flow and retrograde flow from the glands. And I'll show you some pictures here. So this is the blood supply to the penis and the urethra. And as you can see, the urethra receives the blood supply from both the urethral artery and the bulbar artery that come off the common penile artery, but also from circumflex arteries coming down from the dorsal artery, and also retrograde blood flow from the glands back towards in a retrograde fashion. And so again, this is a schema just showing that. As you can see, the urethra receives retrograde blood flow from the glands and also circumflex blood vessels. So even if you detach the urethra here, as in an anastomotic urethroplasty, where there is no antegrade blood flow, you still have blood flow coming retrograde and from the circumflex vessels. There are different methods to bridge the gap in anastomotic urethroplasty. This is your standard reconstructive ladder that was described by Webster. And so basically we're trying to remove the curve of the urethra to help bridge the gap, right? So this is a mid to distal bulbar stricture, and this is a primary anastomotic urethroplasty. Done in a standard fashion. If the stricture is more proximal, the proximal bulb, then we do a parachute repair where we pre-place all our sutures in the proximal bulb and then sequentially take them to the distal bulb and parachute it down. Sometimes it can get challenging deep in the perineum, and so we oftentimes will use the back of our debakis to be able to see the virum montanum, and we'll sometimes sort of modify our needles to form ski needles and place these with the back of the debaki. If the gap cannot be bridged, then augmented techniques using buccal graft or other grafts can be used. Here you can see an augmented anastomotic where one wall of the repair, the dorsal wall, is with graft, and the ventral wall was just a primary anastomosis. This just shows corporal separation. We oftentimes have to do these in patients that have pelvic fracture-related injuries. The key there is to make sure that you identify the dorsal vein and you avoid too much cautery posteriorly where the nerves are. This again shows why that works. So when you separate the crura, instead of this aggressive curve, you can have a gentler curve, and that reduces the distance, as you can see here. Next, you can take a wedge of pubic bone if you still can't get the urethra to reach. And again, doing inferior pubic wedge resection allows not only for this urethral end to reach between the crura, but can also make it a shorter distance right there. I haven't had to do this, and maybe we can ask Dr. Coburn or Max, but you can you can reroute the urethra around the corpora for it to have to reach. In my experience, just splitting the corpora and doing a wedge resection sometimes is necessary, but never a rerouting. So we know that we have different series reporting success rates with anastomotic urethroplasty, and basically they work from anywhere from 85 to 95% at 5 years, which is higher than for a buccal graft repair, but at the risk of some amount of sexual dysfunction. This is in Barbagli's series from Italy, and where he reported about a 20% chance of overall sexual dysfunction. Most of these resolve, most of these are minor, but decreased gland sensitivity is something to be nervous about. So in a young patient, when you're counseling them about an anastomotic urethroplasty, I do mention this very clearly and document this because this is something that you should take into consideration. Mundy's group in London at the University College of London described a non-transecting approach where the urethra is mobilized, as you can see, but not transected. And then you make an incision in the dorsal aspect, not the ventral, but the dorsal aspect. And then you assess the urethra. You see, can we bring the mucosa together in a Heineke-Michelitz fashion? Or do you need to do a primary anastomosis, or do you need to lay buccal graft down? But the ventral aspect of the sponge remains intact. You don't transect the urethra, hence the name. And here, we've just done an advancement flap of the advancement of the urethral mucosa there. And then here's the primary anastomosis if it's a little longer. And it makes sense why you make the incision dorsally, right? It's very similar to a running track, a racing track. And so when you have runners staggered because the inner circumference is much shorter, so they have to run a shorter distance. And so if you have to bring the two ends of the urethra together, you'd much rather bring the dorsal walls together because of the shorter circumference than the ventral walls. In terms of the use of grafts and flaps, buccal graft is now the standard of care, but we do tend, and I'll show you some pictures of penile skin flaps and Orandi flaps and other flaps that we use. Patients who have aggressive disease, either panurethral strictures or post-hypospadias recurrences, we do prefer stage urethroplasties. We published on the use of buccal graft harvest and how patients who chew tobacco and have worse outcomes with urethroplasty after this. You have to be prepared to harvest labial grafts in patients where the buccal grafts are not available. And this slide shows that the substitution urethroplasty, the outcomes are not as good as for anastomotic repairs. They don't have the sexual dysfunction complications, but they don't work as well. And whereas the outcomes plateau for anastomotic urethroplasties, for graft repairs, they do tend to worsen at a rate of about 2% every year. So wherever possible, we tend to do anastomotic repairs, and when the strictures are longer, then we either do a substitution repair, a stage repair, or a composite repair. So there is some data on ventral versus dorsal graft placement. There's one RCT from 2013. It's randomized 40 patients to each group. 55% had bulbar strictures. The rest had penobulbar or penile strictures. And there was a 90% success rate in each group at a mean follow-up of 1 year. There was some bias. In well-done RCTs, you'll see in the protocol that there is allocation concealment and obviously blinding, neither of which were present in this study. And so that downgrades the level of evidence here. This is a systematic review of the dorsal versus ventral graft placement. Again, no difference in ventral versus dorsal. So what are the clinical implications of the evidence here? So we base our decision based on surgeon experience and what each individual surgeon is comfortable with. And then for distal bulbar or penile urethral strictures, we recommend dorsal placement so that it has a better host bed. All right, so this is how we do ventral graft placement. We make a ventral urethrotomy. We cut into healthy urethra for about 1 centimeter or 2 on each side. The grafts are placed, ventral quilting is done, and then the tunica is closed. This is dorsal graft placement while preserving the right side and not doing a right-sided dissection, just doing the dissection on one side, rotating it using traction sutures, placing the graft, and then sewing the urethra back in place. A few special situations, synchronous strictures where a patient has more than one stricture. If it's less than 2 centimeters, we include it in the primary repair. If it's over 2, then we do separate repairs. As you can see here, it was included in the same repair and had a good functional outcome. If patients have strictures in the mid to distal bulb, we do a dorsal graft, as just described. And if there's a concurrent stricture in the penile urethra, then we'll do an Orandi flap or a Macinich flap. So this is a patient that I did an Orandi flap for. My hemostat marks the penile junction. You can see a nearly obliterative stricture in the mid-penile urethra. And so this picture basically shows buccal graft. So this is just the buccal graft there, sutured to native urethra here, native urethra there, and this is the buccal graft. And then the arrow points to the Orandi skin flap, which I'll show again in a second here. So the Orandi skin flap basically is sewed then to the buccal urethra, and this is a composite repair, where the dorsal half is buccal graft and the ventral portion is the skin flap from the penis. In terms of post-hypospadias recurrences, this is a patient that we excised the entire urethra in the penis and replaced it with a buccal graft. That's how it looks 5 days out once you take the dressings down. And then this is how it looks 3 months out. And you can see that the plate, we make sure that the plate is at least 2 to 3 centimeters in length, because you have to accommodate for some amount of restricturing, about 20 to 30%. And so we make the plate pretty broad. In really aggressive cases, we'll use a stage approach using a tunica vaginalis flap in addition to buccal graft. And then for patients who just want a quick outcome, we offer perineal uretrostomy or an augmented perineal uretrostomy, which I'll discuss in a second. So this just shows a standard perineal uretrostomy based on a Blandy flap. We make sure to handle the flap very carefully and leave a lot of fat on it to avoid devascularization. The urethra is opened and the flap is sewed in place using 3-point sutures. Again, taking skin, taking part of the tunica of the sponge in the urethra, not taking the entire sponge, so going over and then going back again into the urethral mucosa. This way you preserve the axial blood supply of the urethra. This is an augmented approach to what I just showed you, plus a buccal graft in patients that have really proximal disease. And I've done this back into the, basically into the prostatic urethra, and it tends to work really well. In patients who have failed primary urethroplasty, we again published our outcomes in the Journal of Urology for how to manage these. And we recommend a DVIU over a dilation. So one attempt of a DVIU in patients who failed a urethroplasty is warranted. Dilations don't tend to work very well in this population. So before urethroplasty, for patients with a new presentation of a stricture, there's no difference between a DVIU and a dilation. They both work poorly. But if a patient has a recurrence after urethroplasty, DVIU is strongly preferred. And these are slides from Dr. Barbagli, and basically showing how he repairs a failed prior urethroplasty. His preferred approach is a SOPA technique, and so you incise the urethra. So this patient's had a prior urethroplasty, had a recurrence in the bulbar urethra. He incises makes a ventral urethrotomy, and identifies the area of concern, extends the urethrotomy, and here you can see the urethral mucosa that's scarred in place, and then again healthy mucosa here and healthy mucosa up there. And so you have two options. You can either excise this entire area and lay buccal graft down, or you can incise it and then do an inlay. And so he's basically incised it and and removed a small portion of it, and you have a diamond-shaped area. I also tend to sort of use the belly of the 15 blade and really distract away the mucosal edges here, so you have a nice diamond-shaped area, and you're staring basically at the corpora, and you lay buccal graft down, quilt it in place, and then close the urethra up. And so in conclusion, urethroplasty provides patients with the best chance for long-term cure. No single type of repair can be presumed to be suitable for any patient preoperatively, and you should be willing to change your game plan. And so being comfortable with different techniques allows you to be flexible intraoperatively. And importantly, better quality studies are needed to advance the evidence-based management of urethral stricture disease. Thank you.